Okay, Assalamualaikum warahmatullahi and salam sejahtera. Good morning. Salam sihat. Malaysia baru. You cannot use the previous term, Now it's Malaysia baru. Ladies and gentlemen, I'm Dr. Hisham Shah bin Muhammad Ibrahim. On behalf of Institute Pediatric, but now we have moved. I think my wards have moved over to the new Women and Children's Hospital. So on behalf of the new hospital, Women and Children's Hospital of Kuala Lumpur, and also on behalf of Malaysian Pediatric Association, we've got our president here, Prof. Yazid here. I would like to thank and give you all a very warm welcome to today's symposium titled Incorporating Pneumococcal Conjugate Vaccination into the National Immunization Program, Learning from Global Experiences. So as you all may be aware, the Ministry of Health, we have been seriously looking into introducing pneumococcal vaccination into the National Immunization Program since 2011. And we've done various initiatives, most notably the policy assessment by the Malaysian Health Technology Assessment, which was published in 2014, which clearly spelled out that I think it is a cost-effective measure to actually introduce the vaccination program. Well, since the report was published, there's been numerous efforts by various stakeholders to address its recommendation. These would also include conducting more studies locally to look at the cost effectiveness and also the serotype distribution, both factors which are important, especially when determining the type of vaccines to be used in our program. So we are also in the process of developing the invasive pneumococcal disease surveillance protocol. So I think this will be dealt later in the afternoon by our colleagues, Dr. Jay Sila and also Dr. Nick Khairuddin. And last year, the MOH has made a commitment to include PCV in the National Immunization Program. I think since the new government took over, there's various announcements by our minister. No, not only that the manifesto states that pneumococcal will be into part of the program, of our immunization program, but I think there's various announcements during his public engagement deliberating on this issue. Yeah. So and then we've applied for funding previously, but I think they are going to actually go again for this budget this year, come national budget announcement 2019, and we hope that we could probably get the support that we require. And as we are gearing up for this budget proposal submission, I hope today's symposium would give us a good platform to gain insights, because we've got our colleagues from South Africa to give them their insights, and we also have got this web conferencing from US, where we can probably learn and discuss on what are the experiences of others in incorporating the PCV immunization in their respective countries. Yeah. So I think our audience today comes from various areas of expertise. I think we've sent invitation letters to a lot of our colleagues. I think we've got quite a sizable crowd. We've got microbiologists, we've got pediatricians, we've got public health specialists, and also we've got policymakers from the ministry to come on board. And then I think we could probably use this opportunity to share experiences and ask questions, deliberate on issues, so that we can actually formulate our local strategies, of how can we move forward with our own initiative in Malaysia. So we've got epidemiologists, and I think even probably nurses as well. Yeah. We hope you will share your thoughts and input regarding the various opportunities and also challenges of how can we include the PCV vaccination in our national immunization program. Yeah. So the symposium today would be introducing a new vaccine into Malaysian NIP, opportunities and challenges. So without further ado, I think can we move on to our first lecture. So to introduce our speaker, who's going to be giving a lecture on introducing a new vaccine into Malaysian NIP, opportunities and challenges, it would be Dr. Aisha Senin. I think Dr. Aisha has spent over 30 years in the field of public health medicine. She received her Bachelor's of Medicine, Surgery and Art of Obstetrics from the Royal College of Surgeons Ireland before pursuing her Master of Public Health in University of Malaya in 1995. And currently she is heading the Vaccine Preventable Disease, Food and Waterborne Disease section at the Disease Control Division, Ministry of Health, Malaysia in Putrajaya. So shall we please welcome, ladies and gentlemen, Dr. Aisha Senin to give her lecture today.
Good morning, everyone. Okay, my topic was given to me is introducing a new vaccine. Okay, just the outline of my presentation, just to bring you through the National Immunization Program and introduction of new vaccine in Malaysia. We'll then go through the pneumococcal conjugate vaccine introduction plan journey, the journey towards this introduction of PCV. A bit about pneumococcal epidemiology and accumulation of body of evidence on PCV in Malaysia. And then I go straight to basically what factors, the challenges and opportunity that we are facing in introduction of new vaccine. For your information, and most of you are familiar with national immunization programs, we have our fair share of success in immunization programs. Our immunization program has started in the 50s. I think maybe we cannot remember, but smallpox was mandatory at one point, and we had eradication of smallpox in 1980. We also have eradicate polio in the year of 2000, and we have as well as eliminate maternal and neonatal tetanus in 2000 as a result of our antenatal immunization of tetanus toxoid. And in 2011, we have achieved control hepatitis B due to our achievement in hepatitis B program. Now our prevalence of hepatitis B among less than 5 is only 0.3, which the target was 1%, and we are aiming towards 0.01%, 0.1% by 2030. In terms of introduction of new vaccine, Malaysia has always been the leader. We were among the first in introducing new vaccines in this region, in the Western, particularly in the ASEAN region. So we introduced HIB, Haemophilus influenza type B vaccine in 2000, and HPV vaccine in 2010. So if you see the stats that I show you there, we seems to be stopping at 2010. Yeah, there's no more new vaccine introduction after 2010. But that's the reality is actually not the case, because in terms of PCV vaccine, we have already started presenting to the highest committee level since 2009. Yeah? So just to tell you the current challenges that we have in terms of NIP and vaccine preventable disease. We recently concluded the EPID review, we call it EPI review, WHO MOH assessment and planning of immunization program, this year in February 2019. And the scope that we review, this is with WHO WIPRO on immunization service delivery, overall vaccination coverage, vaccine supply, budget, quality and safety, the BPD surveillance, and the advocacy and demand generation. So the results of the status of the current Malaysia NIP, if I may read through, Malaysia NIP and BPD surveillance have achieved remarkable progress in regional and global immunization and BPD surveillance targets. The country has well-established and functioning systems of routine immunization service delivery and BPD surveillance. The immunization program is largely managed and delivered by the government. But the private sector also plays an increasing important role. So we noted that we need to engage more private sector in all our planning as well. So the highest priority challenges for us at this moment is identifying, reaching, and vaccinating chronically unvaccinated population. So in Malaysia, we have these populations which are the migrants population, the urban poor, and the anti-vaccines group. Yeah? And secondly, we need to improve our, in terms to interrupt the ongoing BPD transmission. So this is the current, the baseline current challenges that we have at this moment in terms of NIP and BPD. Yeah? So coming back to the PCV introduction plan, the journey in Malaysia. PCV, or the introduction of PCV, is an annual NITEC agenda. We started talking about it in 2009. Yeah? And if you see from 2009, it's almost now 10 years. It's almost every year that we presented to the NITEC committee. So the significant NITEC decision that was made in 2015 was to include the PCV into the drug formulary book for the high-risk cases. Yeah? And in 2016, the NITEC also made decision. At that time, the problem was due to cost, so it was meant for as a beginning for the high-risk cases. But the NITEC also stated that PCV should be included in NIP with statement parents to obtain immunization from the private health facilities. Unfortunately, this was not, it's not being highlighted in most of our endeavor. So, but we know that this PCV has been in the market since 2015, and I think the uptake in the private sector is about 17%. That's the maximum that we got from the pharma industry. And finally, in 2018, as a result of the new government policy on political will in introducing PCV, so the PCV, the NITEC decision is to include PCV in the NIP. And we have submitted a new policy budget at that time, meant for 2019 budget, but unfortunately due to the problem of economy, so it was withheld. But we are submitting again, hopefully with the minister's commitment, and every time you heard about it by him in the media. So we hope that we can get it by 2020, the budget by 2020. That means in that case, the implementation would be 2021 or 2022. But if we get it by 2020, then the implementation will be 2021. Having said that, Selangor actually had started state-funded, they call it Peduli Sihat in Selangor in 2017, and that can offer PCV. Okay. So that is the introduction, that is the journey for PCV. And a bit about the epidemiology. We know that from the WHO weekly review, the source, we had 5.83 million deaths among children under 5 years of age globally in 2015. And the number or the burden of pneumococcal depend on the status in which it vary by country, the study method in which the data is collected, and also the socio-economic status of the country. So it ranged, for example, here in Europe is 44.4 per 100,000 per year, And in less developed nation, it's almost 800 per 100,000 per year. For Malaysia, we have accumulated body of evidence on pneumococcal disease and PCV in Malaysia. And we had one disease burden estimate done locally. Unfortunately, it's unpublished data done by Dr. Tan et al. In 2008 to 2009. It's actually a report, a case report. So 164 cases of IPD admitted into selected government hospitals. From there, the calculations that the incidence of IPD in Malaysia at that time, in 2008 and 2009, is 9.1 per 100,000 under 5 years. And the disease outcome that was collected from these 164 cases, 19% died, 44.4% had required ventilatory support, and 16.5% had neurological deficit upon discharge. The rest recovered. Yeah. We also saw our under 5 mortality data, in which IPD is contributing to that. And from the data, we had 7.8% of the under 5 mortality with subclassification streptococcal septicemia as the main contributing factor, meningitis, and also strep pneumonia. Close to Ministry of Health, we do have Ministry of Health IDS, information data, and these are basically from government hospital only. And the rates of IPD is about 6.5 to 20.9% per 100,000 discharges. Sorry, 6.5 to 20.9 per 100,000 discharges from 2012 to 2018. And in terms of IPD cases, we noted there is an increase in the IPD since 2012 to 2018, almost 266%. But this increase could be due to increased awareness among practitioners, among hospitals, because we believe that the reporting of the discharge coding is actually grossly underreporting. Yeah? When you look at death of children, IPD under 3 years old is also not very high. It's 0.7% to 3.7%. So just looking at the pneumococcal disease cases admitted in the government hospital from 2020 to 2018, it seems that the number is increasing. So this is the closest that we can get to estimate the baseline of the current IPD problem in Malaysia. So we're looking at the coding, ICD-10 codes of as listed there, and currently with the My Data Warehouse, so these data can be churned out very quickly. Okay. As a proxy measure, we look at the age-specific rate per 100,000 inpatient. Again, it's a hospital, government hospital, on the bacterial pneumonia. So there's no specification in what pathogens is actually causing this pneumonia, but it's bacterial. So from there, we can also see the number of cases is increasing. And this is actually age-specific rate per 100,000 hospital discharges for bacterial pneumonia. The highest being the age of more than 55 years old. So we are having problem with the elderly population in terms of pneumonia, followed by children under 5 years old, and under 2 is the blue one. Yeah. So we have actually see that this bacterial pneumonia, well, there are many factors, but we have introduced HIB, Haemophilus influenza type B, so for the past 10 years. So the cohort will be about 10. So in terms of that, the pneumonia among these children is lower. That could be the reason, but this is just a guesstimate. So another body of evidence that we have is the surveillance, the serotype surveillance that IMR is doing. So from the results that we have over the years since 1995, you can see the serotype that is covered by the vaccines. From there, the latest in 2014 to 2017, PCV10 covers 64% and PCV13 87.3%. And in the latest one, the non-vaccine serotypes is 12.7%. Yeah? So this pneumococcal serotype under 5 is being done by IMR, and this will continue. And we hope with the introduction of vaccine, this can be expanded and can cover many more hospitals. Yeah. So again, another, Dr. Hisham Shah has mentioned the HTA on pneumococcal vaccine, the cost-effective analysis. So we know that when it comes to choice of vaccines, PCV13 was predicted to provide higher impact on IPD and community-acquired pneumonia, while PCV10 provides a substantially greater reduction in the acute otitis media. And in terms of adverse events, both are comparable, but the HTA done by Mahtas Malaysia, which review many papers, so they leave the decision to the policymaker. So again, the policymaker has to make decision which one should be chosen when we want to implement. Yeah. So when it comes to challenges and opportunity, we in the Ministry of Health, we have actually established a task force, a community, a committee since 2018. So this committee is looking at all aspects of PCV implementation. So in introduction of new vaccine, we need to look at burden of disease and disease epidemiology. And these are the factors that the NITAC will have to go through with the Secretariat when we presented any plan for introduction of new vaccine. So in terms of PCV, at the moment the data shows small burden, but the sequelae of disease has substantial impact to health service. The impact of introducing a new vaccine, the vaccine need to reduce mortality and morbidity. In order to do that, we need to have a robust surveillance system in place. Yeah? We also look at the vaccine safety, efficacy, effectiveness, and serotype matching. So these are the challenges that we have in terms of information available to evaluate or to assess any introduction of new vaccine. And most of the WHO position paper will be looked at into assessing these choice of vaccine. And of course, the most important part is the cost-benefit analysis and the cost-effectiveness analysis, which we have a lot of evidence regarding this. And in any introduction, even though how good the vaccine is, the programmatic factors are also very important to consider. And these are the immunization schedule, whether it's single or multi-dose vaccines, and whether catch-up immunization is important, because all this will be related to cost and the human resources. Yeah? And in terms of this PCV vaccine, whether we are going to approach the high-risk group B40, for example, or we want to do it nationwide. I think in Malaysia, only Japanese encephalitis is the one that we go for high-risk vaccination, high-risk group, as well as monovalent measles in Sabah. So JE is in Sarawak. So whereas the rest of the vaccines is commonly nationwide rollout, yeah, with a catch-up later. And also the most important is the vaccine cost. I think vaccine choice, WHO has stated the position in 2019, but the vaccine cost, which has deterred us from implementing PCV since 2009, at the moment our expenditure for NIP is approximately 150 million. So introducing PCV is actually exceeded that allocation that we already have. Definitely this is a huge decision by the country if we want to start PCV vaccination. Yeah? And again, what tipped the decision is also the political will. And with this new government manifesto, they have 5 years to honor the manifesto. So we are working very hard actually to try and get this implemented. Yeah. And then when we, the other challenge that we need to look at is Malaysia infrastructure in terms of cold chain. And for this, depends on the vaccine, whether the vaccine needs extra space, because PCV is single use, so more space is being needed. So we, again, the infrastructure in terms of top loading fridges and areas to store the vaccine is also very important. And then on top of that, disease surveillance, which I think has been said earlier. The disease surveillance pre and post introduction. At the moment, we are basing all the evidence from the study and also the selected or limited surveillance done by IMR. So we need to think of what type of surveillance that should be in place, and the committee is actually deliberating on this. Sentinels, having sentinel hospitals, whether a few sentinel hospital with pediatrician or all hospitals, including private and public. So this has to be deliberated. And in terms of notification, whether we want to do it administratively, notification of IPD and pneumonia, or whether we want to do it as mandatory. So I think we are very eager to hear from our colleagues from South Africa, how do they actually do this surveillance. And in terms of serotype surveillance, it's good that we have the baseline, and of course, the post-impact implementation is also needed. So should there be any serotype replacement post-introduction of PCV should be also monitored. Yeah. And at the moment, only IMR is our reference lab for serotype surveillance, but we do have other regional labs, public health labs, that are able to do serotype as well. So in terms of capacity and capability of the other regional labs, should we implement this surveillance, so it should be think about. And that means the money. So when we submitted the application to the government, all this should be taken care of. Yeah? The training of immunization providers. So there will be programmatic changes. Example, what kind of program that you want to do, what kind of schedule, primary and booster, whether it's 2+1 or 3+0. So whether it's a vaccine schedule, whether it's going to be combo together with other shots, because we have to also think of the acceptability of multiple injection in babies. So again, I think with the current problem of parents refusing babies to be injected more than one site, so we need to think about that. Again, we cannot exclude the problem of promotion. I mean, the fund or the financial allocation for promotion, advocacy, and demand generation. And lastly, monitoring and evaluation, which is very important, the vaccination coverage and the impact of the vaccination. At this moment, we are hoping for immunization registry for a very long time. So with the plan of having immunization to be, hopefully we get it through, to be mandatory. So this can be actually included into the plan of regulating immunization. So that is actually a hopeful wish for us in the Ministry of Health to get vaccination mandatory. But again, I think depend on the policymakers, the cabinet, and the rest. Okay. So then what about the post-introduction of vaccine? Again, I think we will go hear today from the other colleagues on the experience from the other countries. But from the discussion that we had, we need to do vaccine effectiveness and cost-effectiveness analysis re-evaluated again once it is implemented. The serotype surveillance provide trending in serotype replacement over time. So this occurs naturally, and we need to actually look at this and continue monitoring on this. And this data may be useful in what type of vaccine we need, and also should we need to change the vaccine later on during the implementation process. And the trend in disease burden, again, I said we need to increase the robustness of our surveillance of disease, particularly in whether we need it as mandatory or voluntary. And if we need it as mandatory, then we need to improve our e-notification systems that we have at the moment. The surveillance on AEFI, not to forget, this is actually the cause of concern of many parents. So whether we need to do active surveillance or passive surveillance, whether we can incorporate to the current system that we have, and the way in which the methods of reporting and investigation, which we need to improve as well at the moment, and the more information materials and FAQ needs to be prepared for vaccine introduction. And of course, in the beginning, we need to have a hotline and risk communication strategies. Yeah? And the most important thing is program sustainability and adequate funding, because these vaccines are very expensive, I think, for Ministry of Health, and government need to set aside continuously for funding of the PCV. This is just to share with you the proposed schedule. The best that we can get is putting in the vaccine of PCV in the second month and third month, and also, this is the current schedule. So we hope that putting in at any of these, probably at 2 months and 4 months and at 12 months. I don't have it here. So this actually to reduce number of visits by parents to come to the clinics, but unfortunately, this will mean multiple injection. Of course, this is being discussed very thoroughly in the committee. Okay, that's it from me. Thank you.
Hello.
Dr.
Thank
Sarora?
you. Yeah. Thank you, Dr. Aisha. That was a very comprehensive updates of the program. Safura from IMU. I'd like to ask, because you mentioned about HPV. Now, one of the main key success in driving that program was the cost-effective analysis that was done earlier by, I think, UKM particularly. And they have really shown the kind of, the percentage or the potential cancer that can be reduced and also the cost that can be saved. Now, was there any studies that you've done or anybody has done, what is the cost-effective and savings potentially that this immunization can bring about, whether it's 10 or 13 or any of those serotypes?
Yeah, I think the paper that we have is that published in 2014.
The modeling, that's the modeling.
Done by modeling done by Tan Kaki and the rest. Yeah,
I'm not sure.
I think it's Hong Kong and Malaysia together. When these papers are being reviewed by MAHTAS, Malaysian Health Technology Assessment Unit, which we have in Ministry of Health. So they are actually advising the NITEC committee. We actually presented, they presented in the NITEC committee in one of those years. I think immediately after, I think 2014, 2015 it was presented. And but the decision was given to the policymakers whether to implement or not. So, well, as I said earlier, definitely the PCV can substantially reduce cases of IPD in particular, because there's a difference between PCV 13 and PCV 10. So substantially reduce IPD, particularly meningitis, and also pneumonia, and the other, and of course the other PCV can also reduce otitis media. So these were the only paper locally that has been done locally.
Yeah, I mean, Dr.
And,
Zul,
yeah.
Okay. I mean, any. I was just looking at Dr. Zul. Yeah, I think there's not many local papers.
Not
that one is
many,
actually just
not,
modeling.
exactly,
but international papers are, I mean, abundant. Looking at the enormous benefit that we could gain from introducing this PCV program. Yeah, Dr. Zul.
Yeah. There are a few papers with regards to cost effectiveness. I think Dr. Syed had done it already, and there's one more looking at synflorix and looking at PCV13. I think there's more data with regard to PCV than there was with regard to HPV. I mean, HPV introduction was, with all due respect to Topa and Zafura, the HPV introduction was actually a very political thing that was brought up by a very strong-minded woman, Minister of Women and Family Development. And I think we didn't have that kind of support with regard to PCV at the time.
Yeah, if you look at the priority by WHO, I think it's quite clear where the priorities would be. So that aside, I mean, the data saying that it is actually very cost effective to actually introduce the vaccine is actually there for us to see. I think probably in the years to come, we can probably come up with our own more accurate data and true representation of what's on the ground. So that's why I think we need all of your support for us to identify the sentinel sites, for us to get the clinical outcome data and whatever is necessary for us to actually come up with our own local, what you call it, cost effectiveness scenarios, so that we can actually share with the rest of the world. Okay, I think we've heard an interesting lecture from Dr. Aisha. Shall we actually thank her in the usual manner?
Baik, Tuan.